Hello, everyone. We are going to get started in just a second. I'm so excited to be doing another Rapid 30 with you guys. We are going to be doing 30 rapid minutes of NCLEX practice questions starting in 1 minute. So get ready. You should see the questions on your screen, up or down, depending on where you're joining in from. And we will just jump right in as soon as we get started in 1 minute, 5 Eastern, 4 Central. For those of you who don't know me, my name is Morgan. I am the CNO at Archer Review, and we are so excited to have you guys here today. This is a really fun, informal 30 minutes. Hopefully, you can take it with you on the go and just have fun doing a little bit of interactive practice. I can answer some of your questions. We can just chat. This isn't, some crazy big webinar. It's just me and you doing some practice together for 30 minutes. So we're calling it Rapid 30. And you guys can let us know at the end if you like this format, if you want more of it, and kind of all that jazz, what you're really thinking about. So let's see. I think that is 5 on the dot. Hopefully we are up and running everywhere, and we will jump right in. So you should see the first question on the board here. You have a client with a suspected retinal detachment. So which statements are going to confirm that? What's going to be consistent with the diagnosis of a retinal detachment? All right, I'm seeing D over there on TikTok, D on Instagram. All right, you guys are most definitely correct. Let's get our rationale up here. D. D is the correct answer. I can see bright flashes of light. Now, I don't know about you guys, but when I started studying, I really got focused in on the curtain coming down. That was what I was most thinking in my head meant a retinal detachment. And I forgot about the bright flashes of light. So don't forget about that one. Curtain coming down, bright flashes of light. Those are all possible signs of retinal detachment. Okay, question number 2 coming up for you guys on the screen. Okay, you're caring for a post-op stroke client, and suddenly they have a fixed and dilated pupil. What would be the most appropriate action by the nurse for this client? Do you want to reduce their environmental stimuli, reassess after 10 minutes, check their blood pressure, or notify the physician? What do we think here? Okay, D, okay. What do we think over here? All right, another D. You guys are thinking notify the physician. And test-taking strategy, remember, you only notify the physician when there isn't anything that you can actively do about the situation, right? If there's an action you can do to help your client, you are going to take it. But if we get a fixed and dilated pupil, what are we worried about, y'all? Herniation, right? We are really, really worried about a brain bleed, surgical emergency. Anything that you do, it's not going to help your client, right? No matter if you reduce their environmental stimuli, check their blood pressure, the actions, it's just not going to cut it. So you guys are absolutely right. In that case, D is the correct answer. We have got to go ahead and let the physician know so that, we can get them to surgery and deal with that accordingly. All right, so moving on rapidly, rapid 30. Here is our next question. This is our first one where we're seeing some lab values. So don't forget, test-taking tip when it comes to lab values. Numbers are just numbers. They're going to give you those normal reference ranges. That's fine. But you have to know what those numbers mean, okay? So when we see a potassium of 5.7, you can tell just from looking at the question, it's a high potassium, okay? But what does high potassium mean? And in this question, I want to know what could cause that high potassium. Cushing's, NG tube suctioning, salt substitutes, hyperinsulinism, adrenal insufficiency. And it's a select all that apply. So which of these can potentially cause high potassium? Okay, I'm seeing C and E, A, B, C. Let's see what's coming on over here. C and E, some D's. Okay. Mixed answers here. It seems like pretty much everyone does want to pick C and E, and then maybe there are a few extras in there too. Those of you who just said C and E, though, you are absolutely correct. So let's go through. C, that high level of potassium can be caused by the salt substitutes because we know salt is that sodium, and if we're trying to make something taste kind of good, but we don't have the salt, we don't have the sodium, we're going to use potassium. So we can get that high potassium level if we're using salt substitutes, okay? Only if we use too much of it. Now, adrenal insufficiency, that was E. Why is adrenal insufficiency a potential cause of hyperkalemia? Well, when you don't have enough aldosterone, remember that's the hormone the adrenals are releasing. So adrenal insufficiency, not as enough aldosterone. And what aldosterone does is help you retain water, retain sodium, and get rid of potassium. So if you don't really have enough aldosterone, you're not going to be getting rid of as much potassium, and that can build up, leading to that hyperkalemia, okay? Now, A, B, and D. Now, why are these incorrect answers? For A, Cushing's, that's going to cause hypokalemia because that is too many steroids. So it's exactly the opposite of what we just talked about with the adrenal insufficiency. We get too much aldosterone and we get rid of a lot of potassium. We end up with low potassium, not this 5.7 that we saw. Now, B, an NG tube dissection. We're going to be taking a lot of stuff out, and one of those things is potassium. So again, it can lead to that low potassium, not high. And then what about D, that high insulin level? Remember, insulin acts like a key, unlocks your cells, and the glucose goes inside. That's how it, controls everything that you're eating. But where does that potassium live? You guys tell me, is potassium living in or out of the cells? Inside the cells, right? We get lots of potassium inside the cells. So if that lots of insulin opens up all the doors, potassium, it can just rush right in there. And again, we get a low level, not a high level. Good job. Okay, Rapid 30, here's our next one. We're going to go and do some discharge teaching. This client has Graves' disease. So which of the following statements would indicate effective understanding? Okay, read through those. We've got Graves' disease. Tell yourself, what is Graves' disease actually doing to the body? Think about it. What is Graves' disease doing to the body? Graves' disease is that hyperthyroidism, right? We get lots and lots of metabolism going on, lots of gas in the car. So will the patient need to report if the pulse is less than 60? Does that sound like something that would happen in Graves' disease if we've got a lot of gas in the car? No, that's going to be more of hypothyroidism, which is the opposite of Graves' disease. We don't have a lot of gas in the car. That's when my body would slow down. What about B? I'm going to add hot yoga to my exercise routine. Is that going to be good for somebody with like a whole lot of extra metabolism? I'm not thinking so much, right? B seems like a pretty good answer. Let's keep it. Now C, I'm going to increase how much fiber I have in my diet. All right. Does this client need extra fiber? Why do we have extra fiber in people's diets? When they need to move things along the GI tract, right? Well, if this client already has a lot of gas in the car, a lot of movement, we probably don't need to add more things to move it along. And I know you guys know D is wrong. I should report if the top number of my blood pressure exceeds 140. Well, here we go. D, we do need to report if the blood pressure is above 140. Because remember, gas in the car, we're going to go. It is going to be really possible that this client's blood pressure goes ways up. Just like we were talking about the heart rate. If that heart rate drops below 60, that's kind of when we don't have enough thyroid hormone, right? But if we have too much, heart rate goes up, blood pressure can go up. So absolutely, it indicates correct understanding if we say, hey, I need to get help. I need to let my doctor know if my blood pressure is above 140. These other ones, they are more indicative of hypothyroidism. Pulse low, adding hot yoga, moving things faster with fiber in the diet. So D here is correct. All right. D here is correct. Now, let's go to our next question for Rapid 30. Let's get into some specialties. Let's look at a client experiencing a suspected placental abruption. Okay, which of the following symptoms would be expected? Think about what's happening in a placental abruption. That placenta is usually attached to the uterus and getting all that blood flow from mama over to baby. If it abrupts or ruptures, we're going to have a lot of bleeding going on. Is it painless bleeding or dark red bleeding? Painless bleeding or dark red bleeding? For an abruption, if your uterus, the placenta is being pulled off of it, does that sound painless? Definitely not. This is going to be that dark red bleeding, Painless bleeding, you guys tell me down in the comments, what is that more indicative of? If I don't have any pain, but I'm bleeding a lot, there's another emergency that you should know has the possibility of painless bleeding. That's placenta previa. For that abruption, it's going to be dark red and it's going to be painful. Now, are they going to have hypotension? They're bleeding. Less volume, less pressure. So absolutely, they can have hypotension. Might their abdomen be rigid? Well, if we're getting all that blood going from the placenta, it's building up in the uterus. It can cause a rigid abdomen. Now, trickiest one, fetal tachycardia. Do you guys think that's right? Do you think that the baby would have high heart rate, fetal tachycardia? What do we think? I'm getting yeses over here on TikTok. I'm getting no's on Instagram. E is incorrect. Let me tell you why, okay? For us, when our blood pressure starts to go down, absolutely, we might have an increase in heart rate to compensate, compensatory tachycardia. But that's not what the fetus does. Remember when you talked about fetal heart rate monitoring strips and we looked at decelerations? We had those variable decels, those late decels. Yeah, when the baby is stressed, that heart rate is going to go down. I would expect fetal decelerations in response to this big emergency, not tachycardia. Is mom's heart rate going to be high? Yeah, she's losing blood. Her heart rate might go up to compensate, but that's not what we're going to see for the baby. So B, C, and D, those are your right answers. B, C, and D. Okay, Rapid 30. We are on our next question here. And now we're going to talk some pharma. We have a client taking their prescribed clozapine. So we need to now decide what clinical data we should monitor, okay? Obviously, for different meds, there are different things we're going to be looking at, but we don't need to look at everything in the world. So think about clozapine. What type of med is it? What does it do to the body? And then use that clinical decision-making to decide what we should monitor. Should we be taking a look at their weight, their CBC, their urine-specific gravity, their fasting blood glucose, or their total cholesterol? Got 5 answers, and we are going to be able to pick as many as we want. We've got to select all that apply here. Remember, for SATA questions, they could all be right, or just one of them could be right. It can be all, and it can just be one. So what do we think we need to monitor? Okay, we've got A and B going on, A, B, and E over here. Most people saying we need to look at that CBC. B seems to be the most common answer. B's, A's, and B's. Okay, let's see the answer. There's actually quite a lot that we need to monitor with clozapine. It is A, B, D, and E. Their weight, their CBC, their fasting blood glucose, and their total cholesterol. Let's talk about why. Clozapine here, it's an antipsychotic, all right? It's one of those atypical ones. So remember, you've got Haldol for your typical antipsychotic, and then you've got clozapine and quite a few other atypical antipsychotics. So of all those antipsychotics, clozapine strongly indicated or implicated, in causing something called metabolic syndrome, where we get disturbances in blood glucose, in their cholesterol, and they gain weight, okay? So we really have to monitor that weight, that cholesterol, and we have to monitor their blood glucose because we know all those numbers can go up. All three of them go up, the cholesterol, the blood glucose, and the weight, if we're getting that metabolic syndrome. Now, there's one other side effect to watch out for, and it is when we have neutropenia, a low level of white blood cells. That's another thing that clozapine does. It really takes a hit on your white blood cells, so you have to watch out for that. And that's why we keep an eye on the CBC. The only answer choice here that we really don't need to look at, the urine-specific gravity. We don't really anticipate renal changes, changes in urine output or electrolytes. So it's not super important to get a urine-specific gravity, okay? The other ones are most definitely needed. So we're gonna make sure to monitor that weight, blood glucose, CBC, and total cholesterol. Okay, you guys, halfway done with Rapid 30. Stay with me. Now we are intubating a client. They're getting an ET tube placed. And you're going to have to verify this, right? Us nurses, we are not actually doing the action of intubation unless you have very specialty training, like maybe a flight nurse. But we got to take care of this client after they get that tube placed. Okay, so what are we going to use to verify? Another SATA, okay? So use your test taking strategies with me, guys. Are we going to get an x-ray, a cuff pressure, look at chest wall movement, an end tidal carbon dioxide? Most nurses will just call this an end tidal. Or are we going to look at ABGs, okay? What do we anticipate the placement of the tube will be verified by? I'm going to go ahead and say right now, all of these tests are things or observations, assessment findings. They're all things that I definitely might look at on an intubated client. I might get a chest x-ray, I might look at their cuff pressure, check their chest wall movement, etc. But that's not what the question's asking. The question wants to know how we are going to verify the tube placement. How are we going to verify the tube placement? All right. And the correct answer is A and D, with an x-ray or with end tidal carbon dioxide, okay? Chest x-ray is your gold standard. That's what we're going to really try to do for every single client, because we want to actually visualize, see that that tube went in their trachea and ends right before that branching of the bronchi. So that tip is called the carina, and we're going to want it to be within like 2 to 3 centimeters of that, okay? We can only do that by seeing it on an x-ray. We don't have x-ray vision. We can't just look at our client and be like, their chest is moving, it's in a good spot. That's not specific enough. Their chest could be moving and the tube could be on one side. So that's why we need an x-ray to see it, gold standard. Now, can we always get an x-ray lickety split right away before we start ventilating this client? No, that's not always possible. We're going to try to do it as fast as we can. But in the meantime, we might use that end tidal carbon dioxide. It's basically a little device, very nifty. You pop it on the end of that tube, start bagging the client, and then watch for color change. Color change is when that little piece on the end of the tube, it actually turns to a different color. Usually it's yellow. And it tells us that there is carbon dioxide in the gas that the client is exhaling. Well, that's great, because if it turns colors and we see, yes, there is carbon dioxide, we know the tube is in the lungs. Where else could the tube go where we wouldn't have carbon dioxide? Into the belly, right? If we accidentally intubate the esophagus, it doesn't go down the trachea, that tube ends up in the belly, and when we ventilate, we don't get carbon dioxide. So color change just tells us, yeah, that tube is in the trachea, and then we got to get a chest x-ray to make sure it's in the perfect spot. So yeah, usually that color change is to yellow. Maybe some people call it gold. It could vary from different facilities and brands and whatnot. But the big thing is color change. It changes colors when it detects that carbon dioxide. So that is a really nifty device. If you're working in an ICU or an emergency department, you will definitely see that end tidal detector. Okay, rapid 30, here's our next one. The nurse is preparing a child who has cystic fibrosis, all right, CF, for chest physiotherapy. This is where we're going to put that vest on and really help move some secretions in those lungs. So before they do that prescribed CPT, chest physiotherapy, what should you do? All right, not a select all that apply. You guys just got to pick one. We got an easy one here. Are you guys going to put on pulse ox, give a bronchodilator, or oxygenate the client via nasal cannula, or ask them to use the incentive spirometer? All right, again, this is why the NCLEX is hard, people. All of these things are totally possible for a kiddo that has cystic fibrosis. None of these are wrong answers, but we are going to be detectives and find the best answer specific to the question. The question wants to know what we're doing before chest physiotherapy. So think about what that chest physiotherapy does. I already told you, you're putting the vest on, shaking them up, trying to loosen up secretions in their lungs so that they can get all of that out of there, okay? So which one of these is going to help with that goal? Which one of these is going to be most useful? Giving the bronchodilator, right? If I make those airways bigger, I can get more secretions out of there. So I want to do that before chest physiotherapy. I don't necessarily need to give oxygen beforehand. They could be satting 100%. A lot of clients really don't need oxygen before, during, or after chest physiotherapy. Maybe some do, but it's not necessary overall. It's not going to help with our goal of breaking up those secretions, getting them out. The bronchodilator absolutely, though, will. Okay, next question coming at you here. You have a client post-stroke. They have had a stroke, and all of a sudden they have a fixed dilated pupil. Wait, we already did this one, didn't we? Skip it. On to the next one. We don't need to do another one twice. We only got 30 minutes together. Okay, here we go. Rapid 30. The nurse is conducting a health screening at a local health fair, okay? Which of the following should they recognize as risk factors for peptic ulcer disease? So you're going to see a lot of these on the NCLEX about a health fair screening. This is part of that health promotenance and maintenance section of your NCLEX test plan, right? How are we preventing disease from happening? Not just treating it once it's already there. So look at these different risk factors here: prolonged ibuprofen use, tobacco use, IBS, H. pylori, and alcohol consumption. And think, if this was happening in my client, would they be at higher risk for developing that peptic ulcer disease? Let's think through it. What about prolonged ibuprofen use? What do you think? Yeah, that should be a dead giveaway. You guys definitely got to know that one. Ibuprofen is an NSAID. NSAIDs are really rough on the belly, right? So we know we use ibuprofen every day for years and years, can increase that risk of ulcers. What about tobacco use? Can that increase the risk of ulcers? Yep, sure can. Can increase the risk of a lot of things, right? But alcohol and tobacco, so B and E here, they are both going to cause more gastric acid to be discharged. We got more acid, can break down those mucous membranes, and we can get more ulcers. All right, what about irritable bowel syndrome? What about H. pylori? No, not irritable bowel syndrome, right? That's not really going to increase our ulcer risk, but H. pylori definitely does, 100%. H. pylori is that bacteria that a lot of times can cause ulcers. It's a gram-negative bacteria. Get it in like contaminated food, water, etc. We always test for that when we're worried about ulcers, because if so, we need to treat that bacteria with an antibiotic. So Pretty much everything on your screen was a risk factor, A, B, D, and E. The only incorrect answer was that IBS. Remember, that's just functional disorder, causes spasms of the large bowel. It's not implicated in causing PUD, peptic ulcer disease. All right. We've already done that one too. Okay. So the community health nurse, we're going to stay in the community here. They have been notified of several incidents. Which of the following requires immediate follow-up? All right, that is a key word going on here in this stem of this question, okay? Because all of these different situations, they might require follow-up at some point. But the question's not asking that. The question's asking which require immediate follow-up. So we've got A, pulmonary TB, and it's still testing positive despite 2 months of treatment. Then we've got B, Hep A, hepatitis A, who works at a cook at a local healthcare facility. All right, that makes me a little bit nervous. Let's see what our other ones are. C, we've got somebody with HIV, and they have an undetectable viral load, and they come in, they report unprotected sexual intercourse. All right, I like that they had that undetectable viral load, right? Their CD4 count, hopefully that's not too low. So, okay, maybe that one's all right. And then we've got D, Lyme disease, and they don't want further treatment with intravenous antibiotics because it is causing them a lot of nausea and vomiting. All right, so all of these reports have come in. Who needs immediate follow-up? Again, I think all these people need follow-up, but just like you guys are saying, B, that cook who works at a local healthcare facility and has a new diagnosis of Hep A, we've got to follow up with that immediately because we do not want them handling food until they've been treated. This is the client who has the highest risk of spreading the virus to somebody else. And if we are a community health nurse, as we are in that very question, we need to look out for the community. We don't want the spread of hepatitis because we've got a cook with a new diagnosis of Hep A who's not undergoing treatment. So when we get that report, we know we need to do something right away so that there's not an outbreak. Okay, all the other clients still needed follow-up. Pulmonary TB, who's undergoing treatment, it's not effective. They're going to need to go 6 to 9 months with those anti-TB meds, okay? So yeah, they're still testing positive. They need more treatment. You know, the HIV with the undetectable viral load, if you can't detect the viral load, no chance of passing the virus to others. So, of course, advocate for safe sex. But again, is that an emergency? It's not an immediate notification. And then D, Lyme disease. Well, if the client is refusing to take their antibiotics, then that's up to them. But Lyme disease, it's not transmitted human to human. So this isn't going to create a public health crisis, right? It's going to go from ticks to humans is how Lyme disease goes. So do I need to talk to that client, figure out, hey, what side effect was causing you not to take the antibiotic, try to help them? We should always advocate for them, but it's not one of those immediate public health concerns. All right, we're going to go 2 more questions, and then that will be it for Rapid 30. Okay, we've got a post-op client. They had abdominal surgery, and now they've got one of those nice PCA pumps, okay? That's going to help them out with pain management. We've got morphine in that pump. The nurse notes the client is still sedated, but they're saying, I am in severe pain. I'm in severe pain. So what action do we take? Should we go up on that PCA dosage? Give a non-opioid analgesic? Discontinue the PCA and just go IM? Let's give them a shot of morphine. Or should we notify the healthcare provider? What do we think here? Okay, I'm seeing some D's, notify. I'm seeing some A's, give them more meds in their PCA. All right, D, a lot of D's. Okay, what do we think here? I agree with you. If we have persistent pain, despite being sedated, there's not anything else in my nursing scope of practice that I'm going to be able to do to help this client. So we need to have attention from the healthcare provider to reassess, figure out maybe there's something else going on. Maybe there's another way that we can help this client and kind of figure out some alternative strategies here. Okay, last question of rapid 30. You have got a client with severe sepsis. Oh, this is my worst nightmare. They are receiving vasopressors, and despite adequate fluid resuscitation, they've still got a low BP. So what intervention should you anticipate is the next step? Think back to your sepsis timeline. If you're already an Archer Review subscriber, you've gone through your on-demand videos, or you've come to our 3-day live review, you know that I review the sepsis timeline. And it says, hey, as soon as sepsis is recognized, our priority is to get a blood culture and get an IV. And then we want to get fluids going. We want to give a broad spectrum antibiotic. And if those fluids don't work for fluid resuscitation, then we give a vasopressor. So this client is here. They've got their vasopressor. They've still got a low blood pressure. What should we do? Bolus them with a crystalloid? Give them CRRT, continuous renal replacement therapy? Should we titrate that vasopressor infusion? Should we give them some blood? Which of these is going to help their blood pressure? Nice job. C, titrate that vasopressor. For those of you who don't know, titration means turning a medication either up or down according to your orders to help manage that client's blood pressure, okay? So if I've got an order for vasopressor, epi, norepi, vaso, dopa, I can turn it up or down based on that client's blood pressure to keep it in range. If this client has a low BP, then absolutely I want to turn that vasopressor up so that their blood pressure comes up. That vasopressor, remember, is going to squeeze on their vessels to make them smaller, and those smaller vessels should have higher pressure. All right, you guys, Rapid 30, that was so fun. We went through a lot of questions today, I feel like. Absolutely excellent job to all of you who hung out. I hope that you liked it. I had a lot of fun with it. Let me know down in the comments if you want more Rapid 30s, if you want to hop on here and do some speedy little practice. If you didn't like it so much, feel free to let me know too. And if you have any last minute questions, you guys want to know about something, you have something specific for me or specific about Archer Review, then feel free to pop it in there, okay? That way we can answer it back to you and make sure that you have all the info that you need. I'm glad to hear you guys liked it. Okay, we will bring you lots more Rapid 30s. Watch out on our socials to see when they're happening. Come hang out and we will keep practicing together. Good luck on your studies, future nurses. Remember, it's hard, but it's worth it. And I'll see you back here next time.